Hello and welcome back to the deep dive. Today, we're doing something a little different. We are not just casually reviewing interesting articles. We are stepping directly into the arena.
And not just any arena.
No, not at all. I mean, we are stepping into the high pressure, high stakes environment of the MD anesthesiology examinations. Specifically, we're tackling a topic that, I'll be honest, strikes fear into the hearts of many residents, myself included, when they see it on the question paper. Renal surgery.
It is certainly a topic that separates the prepared from the unprepared. It's one of those areas where you have the complex physiology, the altered pharmacology, and extreme surgical complexity all colliding in a single patient.
Yeah.
It is the ultimate test of an anesthesiologist's ability to integrate basic sciences with clinical judgment.
Exactly. And we're talking about two distinct but related monsters here. First, radical nephrectomy, where we're taking a cancerous kidney out, and then renal transplantation, where we're plumbing a new one in. And our mission today is very specific. I'm playing the role of the stressed-out resident facing the Gujarat University MD exams, or really any major board exam.
And I'll be the senior faculty mentor, the examiner, if you will, guiding you through the minefield.
Perfect.
And to do this right, we will stick strictly to the Bibles of our profession. We're talking Miller's anesthesia, the 10th edition, Morgan and Mikhail, Yao and Artuzio, and of course the very exam-focused insights from Punit Khanna's long and short cases.
So the goal isn't just to survive the case clinically.
No. The goal is to crush the viva and write a perfect 20-mark answer.
I love that. Okay, so let's start with Part A, Introduction and General Principles. Why is this such a favorite topic for examiners? I mean, besides the fact that they seemingly enjoy watching us sweat over the details?
Well, it's a favorite because it tests your understanding of basic sciences applied directly to clinical practice. A renal case isn't just about keeping the patient asleep. It's about the kidney receiving, 15 to 25% of the cardiac output?
A huge amount.
A huge amount. It's the master chemist of the body. If you mess up the hemodynamics here, you don't just get hypotension, you get organ failure. It forces you to demonstrate that you understand flow, pressure, and the pharmacology in a really compromised system.
So in the exam, if I get a 20-mark theory question like, discuss the anesthetic management of a 35-year-old for renal transplant, where do I even begin? It just feels so overwhelming to structure that.
You begin with the landscape. You have to acknowledge the dual challenge right away to show the examiner you understand the scope.
Yeah.
On one hand, you've got radical nephrectomy.
Right.
Here, you're dealing with a mass, potential malignancy, maybe even tumor extension into the IVC, the inferior vena cava, and significant positioning issues like the lateral decubitus position.
And on the other hand?
On the other hand, you have transplantation. This is a totally different physiologic game. You're managing a patient with end-stage renal disease, ESRD. They have multi-system comorbidities. They're dialysis dependent. And you have that critical heart-stopping moment of reperfusion where the new kidney comes online.
It's so interesting because they're both renal surgeries, but the anesthetic goals are almost opposite in some ways, aren't they?
Precisely. And framing your answer with that distinction, malignancy versus failure, sets you apart immediately. You have to highlight that these are major abdominal procedures with massive fluid shifts and hemodynamic instability.
Okay, let's unpack the general principles first. Before we even think about a specific surgery, we need to understand the terrain. What are the golden rules of renal physiology that I absolutely have to quote to the examiner? I know autoregulation is the big buzzword.
It is. The first number you need to burn into your brain is that autoregulation range. Miller reminds us that renal blood flow, or RBF, is autoregulated. This means the kidney, it keeps its own flow constant despite changes in systemic pressure.
And what is that range? I feel like this is a core fact.
It is. Typically, it's between a mean arterial pressure, a MAP, of 60 to 160 millimeters of mercury.
So as long as I keep the MAP above 60, the kidney is happy. Is it that simple?
In a healthy kidney, theoretically, yes. But here's the nuance that gets you the extra marks. Surgical stress, sympathetic activation, catecholamines, all of these shift blood flow.
How so?
They steal blood from the cortex, the outer part where all the filtration happens, and they shunt it to the medulla. This puts the kidney at risk of ischemia, even if the pressure looks okay on the monitor. So stability is key. You can't rely solely on the mean number. You have to minimize that stress response to prevent cortical vasoconstriction.
That's a great point. Okay, let's talk drugs. This is always a Viva trap. The examiner leans in and asks, Doctor, what muscle relaxant will you use? What is the safe gold standard answer?
The exam-doled answer, without a doubt, is cisatracurium or atracurium.
Because of Hoffman elimination rate.
Precisely. Hoffman elimination is organ independent. It degrades in the plasma depending on pH and temperature. It couldn't care less if your GFR, your glomerular filtration rate, is 0.
So what if I say rocuronium? Is that wrong?
It's not wrong, but you have to qualify it. Kunit Khanna notes that rocuronium clearance is reduced by about 25% in renal failure. It's not strictly contraindicated, but for an exam, stick to atracurium or cisatracurium. It shows you're being cautious and risk-averse.
Got it. What about induction? Is propofol safe?
Propofol is safe, yes. It's metabolized by the liver, not the kidneys. However, Khanna suggests that if the patient is hemodynamically unstable, which, let's be honest, many uremic patients are due to fluid shifts from dialysis, you might consider etomidate.
But generally, propofol is the standard answer.
Yes, but, and this is another key point, you must mention that the dose requirement might be lower.
Why is that?
It's all about protein binding.
Yeah.
Uremic patients have hypoproteinemia, low albumin. Propofol is highly protein bound. So if there's less albumin for it to bind to, there's more free fraction of the drug circulating.
So a normal dose might act like an overdose.
Exactly. You have to explain that mechanism.
And painkillers. I know morphine is basically a dirty word in renal failure.
It is. Morphine has active metabolites, specifically morphine-6-glucuronide, M6G. In a healthy person, you just pee this out. In renal failure, it accumulates. And M6G is potent. It can cause prolonged respiratory depression that lasts for days.
So what's the go-to?
Fentanyl is your best friend here. It has no active metabolites. It's metabolically much cleaner. Remifentanil is also an excellent choice, being broken down by plasma esterases.
Okay, monitors. Standard ASA monitors, obviously. But do I need an arterial line? Is that a must?
For these major cases, absolutely. You need beat-to-beat monitoring. You're going to be manipulating large volumes of fluid, dealing with rapid blood pressure changes. You just can't wait for a cuff to inflate.
And what about CVP? I feel like central venous pressure is the subject of endless debate. Is it still relevant?
It is controversial in modern critical care, for sure. We know it doesn't always predict fluid responsiveness, but for the purpose of the exam, and especially for renal transplant, CVP is still an expected answer. Historically, it was mandatory. We'll discuss the specific targets later, but don't just throw it out. It gives you a trend, if nothing else.
All right, that's a good foundation. Let's move to Part B, radical surgery for renal malignancy. So we're taking the kidney out. What's the surgical context here?
We're usually removing the kidney, the adrenal gland on that side, the upper ureter, and this thing called Gerota's fascia that encases it all. The indication is usually renal cell carcinoma, or RCC.
And the approach matters a lot for us, right? Open versus laparoscopic.
It matters a great deal. Open surgery usually involves a flank incision, which is incredibly painful. It cuts through major muscle groups involved in breathing, so it really compromises respiration post-op.
And the alternative?
Laparoscopic or robotic approaches. These introduce their own set of problems, mainly pneumoperitoneum issues, inflating the belly with CO2. But conceptually, for the exam, you need to focus on the open radical nephrectomy as the baseline for big surgery and the robotic approach as the baseline for physiologic trouble.
And the really scary part you mentioned earlier, the tumor extension.
Yes. Renal cell carcinoma is notorious for this. It loves to grow along the renal vein and then up into the inferior vena cava.
That just sounds terrifying from an anesthesia perspective.
It is. If the surgeon says there's an IVC thrombus, your anesthetic plan changes completely. This is no longer just a kidney case. It's a vascular or even a cardiac case. If that thrombus goes all the way up to the right atrium, you might need cardiopulmonary bypass.
Wow.
So Miller is very clear on this. You must know the level of the thrombus before you even think about inducing anesthesia.
Okay, so let's focus on the preoperative assessment. The examiner asks me, how do you assess this patient for radical nephrectomy? What's my structure? How do I present this?
You use Miller's three-legged stool of assessment. It's a great way to frame it. Leg 1, cardiac reserve.
Okay.
Leg 2, pulmonary function. And leg 3.
Renal function.
Oh.
But specifically the renal function of the remaining kidney. Right?
Exactly. That's the key. You are about to remove 50% of their nephron mass. You need to be absolutely sure the other one, the contralateral kidney, can handle the full load. You're looking at GFR, creatinine. But there's a twist with renal cell carcinoma. It's often called the internist's tumor.
Why is that? I've heard that term before.
It's because of paraneoplastic syndromes. The tumor itself secretes hormones and hormone-like substances. So you have to look for things that don't seem related to the kidney.
Like what?
Hypercalcemia, because a tumor can mimic parathyroid hormone. Polycythemia, because the tumor can release erythropoietin. And hypertension, from renin secretion.
So if I see a high hemoglobin in a kidney cancer patient, I shouldn't think, oh, great, they're not anemic. It could actually be the tumor causing it.
Correct. And that polycythemia increases blood viscosity, which is a big risk for thrombosis. It's a classic exam finding. You have to interpret a hemoglobin of 16 GDL very differently in this patient compared to a healthy 20-year-old. You also need to check coagulation status because malignancy itself can cause a hypercoagulable state.
That's a great clinical pearl.
Yeah.
Okay, let's move intraoperative. The patient is on the table for an open nephrectomy. They're in the lateral decubitus position. This position just sounds like a physiological nightmare.
It is. Let's break it down properly because Miller dedicates a lot of space to this.
Yeah.
The big problem is VQ, mismatch, ventilation perfusion mismatch.
Okay, walk us through the lungs. What's happening?
So the patient is on their side. The dependent lung, the one on the bottom, is being compressed. The weight of the mediastinum, the heart, and the abdominal contents pushing up against the diaphragm are all squashing it.
So its volume is reduced.
Exactly. The FRC, functional residual capacity of that bottom lung, drops. It's very prone to atelectasis.
But gravity pulls blood down to that lung, right?
Right. So the dependent lung gets the most blood, the most perfusion, but it has the worst ventilation. That is a shunt. Blood goes by without picking up oxygen.
And the top lung, the non-dependent one.
The non-dependent lung is easily ventilated because it's open and free. But gravity is pulling the blood away from it, so it gets plenty of air, but less blood. That's dead space ventilation. So you're fighting hypoxia from both ends.
And then there's the kidney bridge. I've seen this in the OR. They crank up the middle of the table to open up the rib space.
And that metal bar pushes right into the flank. Miller warns that raising the kidney bridge can compress the IVC, causing a sudden precipitous drop in venous return and therefore blood pressure.
So when the surgeon says kidney bridge going up, what am I doing?
You are watching your arterial line like a hawk. You are not looking anywhere else.
Yeah.
If the pressure tanks, you tell them to lower it immediately. You don't just start blindly giving fluids. You fix the mechanical problem first.
Let's actually go deeper on this. I feel like we just skimmed the surface of some of these mechanisms. Let's rewind and break down the specific physiology of the pneumoperitoneum when it's combined with the lateral kidney position, because Miller makes a really big deal about this.
You're right. We need to be more granular. Let's think about the robotic-assisted radical nephrectomy. You have the patient in the lateral position, but the robot also requires them to be flexed.
The sort of jackknife position.
Similar, yes. The bed is flexed to open up the space between the iliac crest and the rib cage. This stretches the flank. Now, just think physiologically, what does that flexion do? It pools blood in the lower extremities.
So venous return is already compromised even before they start.
Exactly. Then you add the pneumoperitoneum. Intra-abdominal pressure goes up to, say, 12 or 15 millimeters of mercury. This directly compresses the inferior vena cava.
So preload drops even further.
Preload drops significantly. But here's the paradox that you need to explain in the exam. The head-down tilt, or Trendelenburg, usually increases venous return, right?
Right. Gravity helps drain blood back to the heart.
But in robotic renal surgery, the pneumoperitoneum creates a pressure barrier. It acts like a dam and stops that gravity-aided return. So you get the worst of both worlds. You get high intracranial pressure from being head down, but you get low cardiac preload because of the pressure in the belly.
That is fascinating. So you could see a patient with a swollen face, facial edema, but who is actually hypotensive and volume down.
Exactly.
Huh?
And if you just look at the face and think fluid overload,
Yeah.
and you give a diuretic, you will crash their blood pressure into the floor. You have to trust your invasive monitors. You need to be looking at things like stroke volume variation or pulse pressure variation to really guide your fluid therapy.
This connects back to the whole safe anesthetic concept. Now, fluids during the nephrectomy itself, are we flooding them or are we keeping them dry?
This is where it differs hugely from transplants. In radical nephrectomy, you generally want goal-directed therapy. You do not want fluid overload because that causes interstitial edema, which is bad for healing and bad for the remaining lung. But you absolutely must maintain enough perfusion to protect that healthy contralateral kidney.
So it's a restrictive to euvolemic strategy.
That's the term. Restrictive to euvolemic, you also need to anticipate blood loss. Renal tumors are incredibly vascular. The renal vein is short and wide. If it tears, you can lose liters in minutes. So you need good IV access.
Okay, moving to post-op. Pain control. An open nephrectomy hurts.
It's excruciating. That incision cuts through large muscle groups. Thoracic epidural is the gold standard, according to Miller. It gives you fantastic pain relief.
But you have to check coagulation first.
Always. If you can't do an epidural for whatever reason, TFP blocks, the transversus abdominis plane block, or paravertebral blocks, are excellent alternatives.
And we're avoiding NSAIs, right?
Absolutely, 100%. You have one kidney left, and it's just taken a physiologic hit from the surgery. Do not hit it again with nephrotoxic drugs like ketorolac.
Yeah.
It's just off the table.
Okay, that covers the removal. Now let's switch gears to the main event. Part C, renal transplantation. This is, as you said, absolutely essential for the exam.
This is the bread and butter of the Viva. You must know this inside and out, backwards and forwards.
Let's start with the patient profile. These aren't just cancer patients. These are ESRD patients.
Correct. They have what we call physiological aging. A 40-year-old diabetic who has been on dialysis for 10 years has the arteries of a 70-year-old. They have accelerated atherosclerosis due to chronic inflammation, hypertension, and calcium deposition.
And the surgery itself, you mentioned it's different?
It's crucial to remember this is an extraperitoneal surgery. The surgeon usually places the kidney in the iliac fossa, in the pelvis. They aren't going into the gut, usually. This matters for recovery-less risk of ileus.
Preoperative assessment for the recipient. This is marked as very high yield in our notes. What are the specific questions I absolutely must ask?
The very first question, dialysis history. When was your last session?
And what's the correct answer? What am I looking for?
Kana says the ideal is 24 hours prior.
Why not the morning of surgery? Wouldn't they be perfectly optimized then?
That's a great question, and it's a common trap. It's because of heparin. During dialysis, they're systemically heparinized to keep the machine from clotting. You need a gap of at least 4 to 6 hours for that to wear off. Otherwise, your surgeon will have a field day with bleeding, and you certainly can't put in an epidural safely.
But you also don't want it to be too long ago, right? Because then they're fluid overloaded and their potassium is high.
Exactly. It's a delicate balance. You want them dry, but not dehydrated, and you need the heparin cleared. And speaking of dry, you must ask about their dry weight.
What does that mean exactly in practical terms?
Dry weight is the target weight after dialysis, where the patient is euvolemic, they have no edema, their blood pressure is normal. This is your baseline. If they come to the OR and they're 5 kilograms above their dry weight, you know they are carrying an extra 5 liters of fluid. That dictates your entire induction strategy.
Potassium, the enemy.
The absolute enemy. Kana states that K+ must be less than 5.5 milliequivalents per liter. If it is greater than 6.0, you cancel the surgery and they go back for dialysis. There is no debate there.
Why is 6.0 such a hard line? What's the risk?
Because you are about to give anesthetics. You might have to give suxamethonium, you might create some acidosis, all of which can raise potassium even further. You cannot induce a patient with a potassium of 6.2. You are just asking for a sine wave rhythm and cardiac arrest.
Let's pivot back to the transplant recipient. We talked about physiological aging. Can you expand on the cardiovascular assessment? The sources mention silent ischemia.
This is a huge, huge trap for the unwary. Diabetics with autonomic neuropathy often do not feel chest pain. The nerve fibers that conduct the pain signals from the heart are damaged. They can be having a massive MI and not feel a single thing.
That is terrifying.
It is. That's why Yao and Artuzio emphasizes that a simple ECG is not enough. If their functional capacity is poor, meaning they can't climb a flight of stairs without getting breathless, which most dialysis patients can't, you need a stress test. A dobutamine stress echo is often the test of choice.
So if I'm in the Viva and the examiner says the patient has no chest pain and the ECG is normal, can you proceed? What should I say?
You should pause and say, I would first assess their functional capacity. Given the significant history of diabetes and ESRD, I'm very concerned about the possibility of silent ischemia and would strongly consider further cardiac evaluation like a stress echo before proceeding. That is the consultant-level answer.
And the AV fistula.
That fistula is their lifeline. You must protect it. No BP cuffs, no IVs, no arterial lines on that arm. You can fail the entire exam on that one point. It shows a complete lack of understanding.
Okay, let's move to Part D, intraoperative management in renal transplant. The mantra here is very different from nephrectomy.
The mantra is maximize perfusion. You are planting a new organ that has been sitting on ice. It is thirsty for blood. It needs flow.
So hemodynamics, what are our specific targets?
Kana and Yao both advise keeping the systolic BP greater than 130 millimeters of mercury, or MAP greater than 80. You need a good driving pressure to push blood into that new graft and open up its vessels.
And the anesthesia technique? General anesthesia.
Yes, GA is standard. And rapid sequence induction, or RSI, is often preferred
Why RSI specifically?
because these are uremic patients. They often have diabetic gastroparesis, which is just a fancy way of saying their stomach empties very slowly. They're considered full stomach risks, even if they've been fasting for hours.
Okay. Maintenance. Volatile agents. Is sevoflurane safe? I remember reading something about compound A and it being nephrotoxic.
That is a classic academic debate. Sevoflurane does react with soda lime, the CO2 absorbent in the machine, to form something called compound A, which was shown to be nephrotoxic in rats. However, Miller's 10th edition is quite clear. In humans, with fresh gas flows kept greater than 2 liters per minute, it is generally considered safe. The concentration of compound A just doesn't reach toxic levels.
But if I want to be totally bulletproof in an exam and avoid any debate.
Isoflurane or desflurane are perfectly safe bets. There's no controversy there.
And we stick to atracurium for muscle relaxation.
Yes, stick to the Hoffman elimination agents. And be very, very careful with succinylcholine on induction.
That's another trap, isn't it?
A huge one. Succinylcholine functions by depolarizing the muscle, which causes a release of potassium from the cells. It can raise the serum potassium by 0.5 to 1.0 mmHg. If your patient's already starting at 5.4, that little push could send them into a fatal arrhythmia.
So only use it if I know the K+ is normal.
Only if you have a recent lab value showing it's normal. If in doubt, rocuronium is always a safer choice.
Let's talk fluids. This is the exam favorite. How do we manage fluids in a transplant? It feels counterintuitive for a patient who can't make urine.
The strategy is volume loading. You need to fill the tank before the surgeon releases the clamps on the new kidney.
And what about CVP targets? You mentioned there's been a change in thinking.
Yes. Traditionally, we were taught to push the CVP up to 12-14 millimeters of mercury. We would practically drown the patient to ensure the kidney worked. But Miller's 10th edition reflects a more modern, nuanced shift. We now know that excessive fluid causes pulmonary edema and bowel edema. So a more conservative CVP of 7 to 9 is acceptable, provided the MAP is well maintained.
The choice of fluid matters too, right? Normal saline versus a balanced salt solution.
This is absolutely crucial. You must not use normal saline. That's 0.9% ACL if you can avoid it.
Why? It's the standard fluid everywhere else.
Because it causes hyperchloremic metabolic acidosis. Let's just look at the chemistry for a second. Normal saline has a chloride concentration of 154 MEqL. Your plasma has a chloride of about 100.
So it's loaded with chloride.
Massively. It comes down to something called the strong ion difference, or SID. When you pour in that much chloride, you decrease the SID. To maintain electrochemical balance in the blood, hydrogen ion concentration increases. And that is hyperchloremic metabolic acidosis.
And as we said before, acidosis shifts potassium out of the cells.
Yes. The cells are little bags of potassium. When the blood gets acidic high, H+, the cells try to buffer it by taking in H+. To keep the electrical charge balanced, they have to kick out a potassium ion. So saline leads to acidosis, which leads to hyperkalemia.
That is crystal clear. So saline actually makes the potassium problem worse.
Exactly. You should use a balanced salt solution like Plasmolite or Ringer's lactate.
But wait a minute, Ringer's has potassium in it. Isn't that dangerous in a patient who already has high potassium?
That is a very common misconception and a great Viva question. The amount of potassium in Ringer's is tiny. It's 4 mmHg. It's physiological. The acidosis caused by giving liters of saline is far, far more dangerous for potassium levels than the tiny amount in Ringer's. But Miller and Yao are very clear on this.
Okay, we're in the OR. The surgeon has sewn in the vessels. We're approaching reperfusion, the crunch time. What happens?
Surgeon looks at you, gets a nod, and then unclamps the vessels. Blood rushes into the new kidney for the first time.
And the BP drops.
Usually, yes.
Yeah.
You often get sudden, sometimes profound hypotension.
Why? What's the mechanism?
There are two main reasons. First, you have 300 to 500 milliliters of blood suddenly filling this new organ. It's like a sudden internal hemorrhage into the graft. Your circulating volume drops. Second, you have washout.
Washout.
The new kidney has been on ice. It's full of potassium, acid, and vasodilatory metabolites from being ischemic. All of that junk flushes out of the kidney and hits the systemic circulation all at once.
So you get vasodilation on top of volume loss?
Precisely. And this is also where something called reperfusion injury happens. When oxygenated blood suddenly hits that ischemic tissue, it generates reactive oxygen species-free radicals. This causes inflammation and can stun the kidney.
And this can lead to that delayed graft function we talked about.
Yes. It's basically the kidney being stunned right at the start. Anesthesia can help minimize this.
How?
By maintaining a high perfusion pressure. If the new kidney opens up and the systemic BP is low, the small vessels in the graft can collapse. You need to keep them stented open with pressure. That's why we often run the SBP up to the 140s right at the moment of reperfusion.
I often see surgeons asking for mannitol or Lasix right before this. Why is that?
Yes, that's very common. Mannitol is an osmotic diuretic, but it's also a free radical scavenger, so it helps combat that reperfusion injury. And furosemide, or Lasix, helps to jumpstart diuresis. It's often given just a minute or two before the clamps come off.
So how do we manage this critical moment? What's the plan?
You anticipate, you bolus fluid before the surgeon even touches the clamp. You have your vasopressors drawn up and ready, phenylephrine, ephedrine, whatever your choice is. And you check the BP and a blood gas for potassium immediately after.
Okay. Moving to Part E, postoperative care. We're in the PACU. What are we looking for? What's the first thing we check?
Urine. Urine is liquid gold. We want to see a nice, steady stream, ideally greater than 100 milliliters per hour.
And what if there's no urine? Anuria. That's the nightmare scenario, right?
It is, and you have to rule things out systematically. Don't panic. First is the urinary catheter blocked or kinked. Flush it. That's the simplest fix. Second is the blood pressure adequate. If the MAP is 60, that kidney's not going to work. Push the pressure up.
And if it's not those two?
Then you start thinking surgical causes. Is the artery kinked? Is the vein thrombosed? That requires an urgent ultrasound. And finally, you consider medical causes like acute tubular necrosis or ATN.
What exactly is delayed graft function?
DGF means the kidney doesn't work right away. The patient needs dialysis in the first week post-op. It's usually due to ATN from a long, cold ischemia time, meaning the kidney was on ice for too long, which is more common with cadaveric donors.
What about the opposite problem? Polyuria, too much urine.
That happens too. It's called high output failure. The new kidney can filter blood, but its tubules are still stunned, so it can't concentrate the urine yet. It just dumps water and electrolytes.
So the patient can get dehydrated incredibly fast.
Extremely rapidly. They could pee out 500 milliliters or even a liter an hour. You have to chase it, liter for liter, with IV fluids. If you don't match the output, they will become hypovolemic, their pressure will drop, and the new graft will clot off.
It sounds like a complete roller coaster.
It is. The first 24 hours post-transplant are a constant hemodynamic balancing act. You're basically an intensivist in the recovery room.
Okay, Part F, comparison and exam integration. This is where we tie it all together for the listener to make it easy to remember. Let's visualize that table. Nephrectomy versus transplant.
Let's do it. First row, patient. Nephrectomy is a cancer patient who often has normal baseline renal function. Transplant is an ESRD, patient sick, uremic, hypertensive, diabetic.
Next row, fluid strategy.
Nephrectomy is restrictive to euvolemic. Transplant is liberal and even hypervolemic to drive perfusion into the new graft.
Potassium.
Nephrectomy, usually normal K+. Transplant, chronically high and very labile K+. It's your main concern.
And incision.
Nephrectomy is a big flank or retroperitoneal incision. Transplant is a smaller incision in the iliac fossa.
That's a great summary. Now hit me with the Viva traps, the questions I ask specifically to see if you'll fail.
Trap number 1. Doctor, the patient is on dialysis. Can you put the BP cuff on the left arm? You must immediately ask, where is the fistula? If you put a cuff on a fistula arm, you can thrombose it. That is an instant, unrecoverable fail.
Okay, trap 2.
Would you use succinylcholine for induction? We've discussed this. The only safe answer is, I would only consider it if I have a recent blood gas confirming the potassium is less than 5.5. If you don't know the K+, you say rocuronium.
And trap 3.
The patient is anuric post-op. What is your very first action? Do not say give Lasix. Your first action is to flush the catheter to rule out a simple mechanical obstruction.
That is gold. I want to touch on one more thing, local anesthetics. We talked about blocks. Do we need to adjust the dose in renal failure?
Yes, absolutely. Kana points out that in chronic renal failure, you have a hyperdynamic circulation, so absorption of the drug from the tissue into the bloodstream is faster. But more importantly, the seizure threshold is lower in uremic patients.
So they are more likely to get local anesthetic systemic toxicity, or ALAST.
Correct. And because they often have a background metabolic acidosis, the protein binding of local anesthetics changes. You have more free drug floating around. So the recommendation is to reduce the maximum allowable dose of your local anesthetic by about 25%.
That is a very specific high-yield nugget. Reduce lidocaine or bupivacaine dose by 25%. Got it.
And also, regarding blocks, coagulation. We mentioned heparin from dialysis. But uremic patients also have something called platelet dysfunction.
Even if their platelet count looks normal on the lab report.
Yes. Uremia acts like a toxin. It coats the platelets and stops them from sticking together properly. It interferes with the release of the factor VIII von Willebrand factor complex. So it's a qualitative defect, not quantitative.
So how do we even test for that?
A standard platelet count won't show it. In the old days, we used bleeding time. Now, we might use TEG or ROTEM if they're available, but clinically, if the patient has signs of active uremic bleeding like oozing gums or easy bruising, you should be very, very wary of putting a needle in their back for an epidural.
Is there a fix? Can we clean the platelets or help them?
Dialysis itself improves it. But if you're in a pinch, desmopressin or DDAVP can help. It forces the release of von Willebrand factor from the endothelial cells and helps the platelets stick. Cryoprecipitate is another option in an emergency.
Let's spend another minute on that comparison table for the exam. I want to make sure I have the post-operative concerns row correct.
Okay, good idea. For nephrectomy post-op, your main worry is hemorrhage, a ligature slipping on the renal artery, pain leading to atelectasis and pneumonia from splinting, and acute kidney injury of the remaining kidney. For transplant post-op, your main worry is graft thrombosis, which is a surgical emergency, a urine leak from the anastomosis, rejection, and of course, infection.
Infection. We haven't talked much about immunosuppression.
Good catch. These patients are on some heavy-hitting drugs. Steroids, tacrolimus, mycophenolate.
And what does that mean for me, the anesthetist?
Two things. First, infection risk. Strict asepsis is completely non-negotiable. You do not touch their central line without full sterile precautions. And second, stress dosing of steroids. If they're on chronic steroids, their own adrenal axis is suppressed. They might need a boost of hydrocortisone to handle the physiological stress of surgery.
Okay, let's tackle the exam presentation. You mentioned the 20-mark answer. How do I actually write the introduction to make it stand out?
You start with a hook, something professional and concise, like, renal transplantation is the definitive treatment of choice for end-stage renal disease, offering superior survival and quality of life compared to long-term dialysis. The anesthetic management is uniquely focused on optimizing the recipient to accept the graft, specifically by managing their complex cardiovascular, fluid, and electrolytic stability.
That sounds really professional.
It sets the tone. Then you use headings. Examiners are scanning for keywords. Headings like preoperative optimization, intraoperative monitoring, and management of the reperfusion phase make it easy for them to find the points and give you marks.
And for the Viva, when they ask a question, do I just blurt out the first answer that comes to mind?
No.
Right.
Clause. Take a breath. Structure your answer. If they ask, how do you manage hypotension during a transplant? Don't just say, ephedrine.
So what should I say?
You say, my approach would be to first assess the cause. Is it a preload issue? Is it a contractility issue? Or is it an afterload issue? In a transplant recipient, I aim for a systolic blood pressure over 120. I would first ensure adequate preload with a fluid bolus, aiming for a CVP of 7-9, and if unresponsive, I would then use a vasopressor like low-dose phenylephrine to maintain perfusion pressure to the new graft.
That sounds like a senior resident speaking, not a student.
That is the goal. You are not a student anymore. You are a consultant in training.
One last specific question from the sources. Morgan and Mikhail mentions closing capacity. Does that apply here?
It does, very much so, especially in the nephrectomy patient in the lateral position. Closing capacity is the lung volume at which the small airways start to close. It increases with age.
And anesthesia reduces FRC, or functional lung volume.
Exactly. Anesthesia reduces FRC. The lateral position reduces the FRC of the dependent lung. So if your closing capacity exceeds your FRC, your airways are closing during normal tidal breathing. This explains why you get atelectasis and hypoxia and why we use PEEP positive and expiratory pressure.
But too much PEEP is bad for the kidneys.
Yes, it's a delicate balance. Too much PEEP can decrease venous return by compressing the IVC, and that can reduce renal blood flow. So you use just enough. Usually 5 to 8 centimeters of water of PEEP is the sweet spot.
This has been incredibly comprehensive. I honestly feel like I could walk into the exam hall right now.
Just remember the 3 pillars we discussed for the exam.
Understand the physiology, autoregulation in the kidney, hypoxia in the lateral position.
Respect the potassium. It kills.
Know your fluid strategy. Know when to restrict, like in nephrectomy, and when to load, as in transplant.
Perfect. Thank you so much for this.
My pleasure. Good luck.
And to our listeners, good luck with your studies. You've got this. Keep diving deep.
Goodbye.
See you next time.